everybody. So this should be a lot of fun. I'm going to lead off with just a couple of slides kind of introducing cerebral aneurysms and some of the challenges that we have in detecting and monitoring them, but let's launch into it. So I'm going to briefly introduce Rapid's new Rapid Aneurysm product, and then we'll talk about detection and monitoring of aneurysms. So Rapid Aneurysm is an artificial intelligence software platform, and it's currently a semi-automated way to detect aneurysms on CTA and MRA studies. And as you can see from this little image on the side here, what the software does is it takes a 3D surface rendering of the vessels from these non-invasive studies, and then it is able to detect the presence of the aneurysms on there. For the neurointerventional folks that are watching this, you can already see from this one image the striking resemblance to a digital subtraction angiographic image compared to what we typically are seeing on cross-sectional imaging. So aneurysms are a do not miss lesion for the radiologists out there. They're commonly seen on CT angiography. Increasingly, we find them when we're doing CTAs for something else. But that's important because you do not want to miss these. And if you're reading a study thinking about a stroke or some other problem, you may be less attuned to the presence of an aneurysm. So there's certainly a role to have some help to the radiology folks in detecting these aneurysms. The typical CTA study has a lot of images, and an aneurysm may be present on 1 or 2 slices. So any help you can get, that's really helpful. And of course, aneurysms can be small, and they may be multiple in number. And those are certainly factors that can lead to them being missed on these non-invasive studies. So we're going to look at examples of aneurysms going forward, but these are just one little picture of several aneurysms detected by the Rapid software platform. So another thing that's important for people who take care of aneurysms, like all of the panelists today, not every aneurysm needs treatment. Okay, some of them are quite small but need to be monitored. And what you're looking for is growth of the aneurysm, change in shape of the aneurysm, which may indicate that that aneurysm should be treated. And just a way to introduce this is one of my patients. You can see that the software here has detected 2 separate aneurysms, an ACOM aneurysm and a left anterior choroidal aneurysm. And you can see that the initial measurements here are pretty small. Okay, so the first measurement we see is 4.8 millimeters in greatest dimension for this aneurysm. This was too small to treat the patient based on her desires, so we followed it. The next study, a little bit bigger, 5 millimeters, but most of us would say that may be within the margin of error of what you would measure on a non-invasive study. But then the next follow-up 6 months later, clearly we're seeing a trend where this aneurysm is growing, and now it's over 5.6 milliliters. An aneurysm that grows is kind of a harbinger of it being a bad actor. So those are just a few slides to kind of introduce the concepts that we're going to be talking about going forward and to show you a few little imaging examples of it.
I'm going to present a couple cases of patients who underwent a serial aneurysm screening who had autosomal dominant polycystic kidney disease. And as you all know, this is a disease where there's a much higher frequency of cerebral aneurysms than there are in the general population. And patients do undergo regular screening. At least at Mayo, we do it at 1 to 2 year intervals, whether or not an aneurysm is found on the initial MRI, because they are known to have de novo aneurysms as well. So this is a patient who in 2006 was in their 30s, who had autosomal dominant polycystic kidney disease. And you can see here on this MR angiogram that there is this small ACOM aneurysm with this tiny little daughter sac. And at the time, the patient knew about the, learned about the aneurysm, but did not want to undergo a treatment. At the time, I think surgical clipping was offered. Here is the MRI that's performed on the patient in 2014. And you can see here, even without the ruler, that the aneurysm, it looks like it's grown a little bit. And then you see this little daughter sac right here. So, these are just kind of little projections from the 3D reconstruction of the MRA, that were done at the time. So we ran the aneurysm, we ran the whole MRA through the Rapid Aneurysm Detection and Monitoring software. And you can see here, this is the image from 2006, where you can see the aneurysm right here. You can see that little daughter sac that we saw earlier. And you see here in 2014, that, there's been, obvious growth of the aneurysm, including the daughter sac. So in 2006, we saw the aneurysm measured about 6 millimeters in maximum size compared to 8.4 in 2014. And overall, the volume of the aneurysm, we see only like a 2.5 millimeter increase in maximum diameter, but the volume of the aneurysm almost doubled over that time as well. And then this is kind of nice because then you can kind of get like your working projection, showing kind of the neck dome interface and how the measurements are obtained. And you can see here how the maximum diameter measurements were obtained. You can see here how that daughter sac or that secondary lobule had definitely increased in size over time. And then you can actually do an overlay comparing, the MRA from 2006 and then the MRA from 2014. And you can see how overall the volume of the aneurysm had significantly increased in size. You can also see how the size of that daughter sac, that worrisome area, also increased in size as well. And this is something that I think, it's probably very nice to be able to explain to the patient, whether or not there is growth, to show like, oh, look, there's a little bit of growth, or there's a lot of growth. And I think that anybody, even if you don't have a medical background, can appreciate, the amount of growth or lack thereof seen in an aneurysm, particularly with the overlay type images. So, this patient, this was in 2014, and, they went on to get a surgical clipping of this aneurysm.
Let me ask you this. I know in my clinic, I have many patients where I'm following aneurysms, and I always look at the pictures with them because I think that that's really important for patients to see it. Can you just comment on, is that what you do, and how patients really respond to kind of visually seeing either a new aneurysm or growth of an aneurysm, and how that maybe influences their wanting to talk about treatment?
Yeah, no, I mean, I think it's so important to go over imaging with the patients because, I know it's an old adage, but, picture's worth, 1,000 words, right? So, I mean, that, this is a picture that you can see right here, that this is enough to explain to a patient like, hey, this is something that, likely warrants treatment, right? Like that's enough. But then it's also good, in cases where you don't see that, and, a patient might be really anxious about their 3 millimeter superior hypophyseal aneurysm, and you don't want to treat the patient, because you don't, maybe they're low risk, and, it's a benign aneurysm, and to be able to show a patient like, hey, here's your, aneurysm, and look at this overlay, potentially, say, look at this overlay over 5 years, like nothing has changed. I think that could give a patient a lot of confidence.
Yeah, that's great. Okay, so I think, thank you, Waleed. That was really great. Let's move on. And I think, Brian, you're up next with some of your cases.
Welcome, everybody. Good afternoon. Waleed, I thought those cases were quite illuminating, and I would treasure the ability to show those images to my patients, just like Jeremy pointed out. So it's coming, and I look forward to that day very much. Once again, I'm Brian Jankowitz. I'm a neurosurgeon at the University of Pennsylvania. And I just wanted to highlight one simple case that really touched on all of the issues that Jeremy pointed out. We often obtain CTAs for reasons other than screening for aneurysms, as was performed in this 54-year-old female that underwent a screening, actually an image-guided CTA, as she was about to undergo a left-sided retrosigmoid craniectomy for resection of an acoustic neuroma. And no one was thinking about aneurysm, and we almost missed a very small left M2 segment aneurysm, because the only reason that CTA was ordered, once again, was for a completely different reason. Most aneurysms are small, as this CT initial CT at least will highlight, and some aneurysms do grow, which really necessitates close follow-up for many of these aneurysms. So this was the initial CTA on the left in October of 2018, and you can see there on the left distal sylvian fissure what could just be a vessel turned on its side, where it looks like a bulbous projecting vessel. But you can clearly see that 2 years later, that M2 segment aneurysm has enlarged dramatically. Here's a coronal early CTA in 2018 and a follow-up in 2020 that shows really dramatic enlargement of this distal M2 segment aneurysm. So we ran the 2020 CTA through the imaging software and really came up with these beautiful images that once again highlight all the things that Waleed just showed. The ability to evaluate the neck of the aneurysm, the maximum diameter, the total volume, and quite impressive too that it was able to pick up really more of a fusiform aneurysm. This is really a blowout of that entire segment of that ear inferior M2 branch, really highlighted best here, and yet that the software was able to pick it up quite accurately and sensitively. We ultimately underwent a catheter-based angiogram to further evaluate this aneurysm and performed a classic 3D DSA. And what really struck me was the similarity between the 3D reformatted images on our new Siemens Icono 3D DSA and the reformatted images on the RapidAI imaging algorithm, really giving us quite similar images that I think I would be very comfortable evaluating, showing to a patient, and even potentially coming up with a treatment plan all from this reformatted CTA.
Let me ask you a little bit more about that last statement, because that's also pretty striking to me, where you can look at an aneurysm on a CTA or an MRA, and sometimes I find myself telling the patient, look, maybe this could be just coiled, maybe this would need a stent coiling, maybe this is amenable to a web device. Whereas I feel like what you just showed would be much more clear in how you might consent a patient for treatment ahead of time. Could you maybe talk a little bit about that?
Sure. I mean, I just for interest to everyone, I perform a catheter-based angiogram on every aneurysm that I intend to treat. Sometimes I feel like it probably wasn't necessary, particularly if I had the ability to reformat these images in an easy way, and I stress it, in an easy and really enjoyable way, because you can reformat MRAs and CTAs and obtain very similar images, but I can't, in the comfort of my office, or I at least can't request or manipulate those images in a facile way that can expedite the evaluation of a complex CTA or MRA. So I think it's very important to have the ability to obtain unique images and different projections. It absolutely and fundamentally changes the way I think about aneurysms, whether I coil, balloon remodel, web, stent coil, or ultimately clip. So all those all those reformatted images that I show are absolutely necessary. And it's interesting. I could foresee the day when after just running an aneurysm through this algorithm, I might bypass the catheter-based angiogram for diagnostic reasons and go right to a treatment paradigm.
Thanks, everybody. Really happy to be a part of this. And a great intro. And Waleed and Brian, those are fantastic cases, really impressive results, and really developed some really good concepts. I'm going to show 3 or 4 cases, ones in which we had a CT or MRA, sometimes both from outside hospital, all of which had a DSA as the gold standard to compare to see how the software functioned. And I'll show reconstructions and aneurysm detections off of CTAs, MRAs, and even 3D rotational angiograms, which is another feature that's available. And I really, as I'll show you, I really was throwing some difficult aneurysms. I really wanted to find the limit of the technology. Of course, by finding the limit is you can work towards pushing those boundaries. So I really will show some cases that highlight that. And here's the first one. This is a straightforward. This is not a curveball or a challenge. This is the warm-up round. But here you see this aneurysm, and I have different projections here, the CT angiogram, the lateral view, and the corresponding 2D angiogram. And this particular case was reconstructed off of this of the CT angiogram. So there's the aneurysm being detected off the CT angiogram. And again, as the cases you've seen previously, we have nice automated measurements, the neck, the height, and the width. And of course, you can rotate this around and look at it in every kind of way you'd like to understand the local anatomy, the relationships to nearby vessels, etc. And here's that same aneurysm case, but this time run on the 3D rotational angiogram. So again, similar results, really accurate down to the measurements. Again, just showing you can run the software through both the CTA, MRA, and also a 3D rotational angiogram. Here's a case that was along the skull base, a medially projecting cavernous aneurysm. You can see again the measurements. This one was run off of a 3D rotational angiogram. Again, be able to manipulate and really nice clear anatomy and shown that aneurysm quite nicely. And then here's a case of a 45-year-old female had undergone screening imaging for a family history of aneurysms. And on CTA here in the corresponding 2D DSAs and the 3D DSA, you can see this very ugly MCA that we definitely treated. And here's the corresponding reconstruction with the rapid aneurysm software off of the CT angiogram. You can see that morphology of the MC aneurysm, and again, the measurements, dome, height, width, neck, and maximum size. And I threw this at it because we're talking about aneurysm detection with AI helping or assisting humans, not replacing us, but assisting us. So I wanted to throw a multiple aneurysm, and the next one even has more aneurysms. And of course, a machine is not going to be distracted like a person would. So here, I really did not expect this aneurysm, which has sort of this bird on the wire, like a little pigeon on a wire appearance, just beyond the MC bifurcation, a very small, oddly shaped aneurysm with a maximum diameter just over 3 millimeters. And I really was not expecting this to be picked up. In this case, the aneurysm software off the 3D rotational angiogram source picked it up quite nicely. You can see here the measurements, and again, you can manipulate it and look at it in all different kind of angles. And also off the MRA, so that same case, but off the MRA, it also detected the MCA I wasn't surprised about, but that smaller MCA aneurysm just beyond the bifurcation also picked up off the MRA. So again, we're looking here from above, rotating. Here's the measurements in great detail. There's 2 aneurysms. Again, the smaller the aneurysms, measuring just over 3 millimeters. So I was quite happy that this was picked up on a couple of different modalities. Again, glad to be part of this group, and really exciting things ahead. What a time to be doing neuroendovascular work. I mean, what a phenomenal time. But the next 10 years are going to be amazing. I'm just happy to be part of it.
This is an 80-year-old. She's got a history of 14 aneurysms. She presented more than 20 years ago with a subarachnoid hemorrhage and had clipping of 2 MCA aneurysms and a PCOM by one of my partners. And she had sort of intermittently lost a follow-up, but then in 2013 was noted to have one of the very large aneurysms of the ICA segment was growing. And so that they attempted to treat that. And due to significant tortuosity, it was aborted and again, lost a follow-up. Although she came later for further follow-up imaging when she had this sort of, again, giant ICA aneurysm, the same one that was attempted treatment in 2013, and had basically at this point doubled in size, and she was also having associated neck pain. Now, the other aneurysms we measured, I measured again and compared them back to the older imaging, were roughly stable in size from 2020. And I think this is, one element where the software is really helpful because every time this patient gets imaging, for me to line up all the imaging and measure all 14 aneurysms, it's at least a half an hour, if not more, of my time to make sure that I've got them lined up and I'm really, correctly, appropriately checking each one. So, this is probably my usual patient down here in Miami. And, and that's part of the reason that this patient was being monitored over time. But basically, this is the one that had more than doubled in size multiple times, and it was treatment was attempted in 2013. You can see this giant, partially thrombosed ICA aneurysm with multiple other associated aneurysms. Here, you see slow flow of the distal outflow carotid, and she has a matching one of these aneurysms on the other side. You can also see here another thing that's not great about this is the stenosis of the outflow. And this is part of the reason that they had so much trouble in 2013. But now, again, it's doubled in size, so it's 4 times bigger. The fellows are all excited about these cases. My general feeling is not excited. But ultimately, we were able to treat this. We used a balloon anchor technique to pull up a flow diverting stent. You can see the flow diverting stent here. And then we're able to go on and coil this and occlude this. So, then she gets a 6-month follow-up. Again, I spend my 30 minutes measuring out all of her 13 other aneurysms, which are all stable in size. Then she returns at 1 year. Now she's got new right arm and leg weakness. Again, the MRI shows multiple left-sided embolic strokes. The TTA is negative. The MRI also shows that the left sort of matching ICA aneurysm has grown significantly with new clot in the aneurysm. We got transcranial Dopplers with emboli detection study, which showed multiple emboli over 30 minutes from the left ICA aneurysm. So this is that one. Another reason that I was very unexcited to treat this. It's a little bit hard to even figure out what's aneurysm and what's vessel. This is sort of what you can see here with the arrow is in the delayed imaging. This aneurysm actually much bigger on MRI than it is on angiogram. And something like the Rapid software can pick up these partially thrombosed aspects of the aneurysm and really show us, these aneurysms are growing. This is the true lumen of the aneurysm. It's kind of confusing to understand, even where the normal vessel is. And so given that this was a symptomatic aneurysm and it would also increase significantly in size over time, I then went on to treat this one. And this one, because there's so much clot in the aneurysm, I treated this with overlapping pipeline stents. You can see here, this is multiple overlapping pipeline stents. This is the result of that aneurysm. And then this is on further 1-year follow-up. So this is the one that we treated with multiple overlapping stents. And then the one on the left is now had 2 years of follow-up without any recurrence. And that's the flow diverting stent with the coils. So, I think, thanks very much, for allowing me to participate in this. I think that the one area that this software can really make this easier is, saving us a lot of time. And you have a lot of these patients where you're following the imaging. It's a tremendous amount of work. And the software can potentially condense that and make it easier, safer, faster, and more effective.
I'll pivot back to you first, Bobby, and then Alex and Waleed, hear your opinions. So, people are wondering when they go see their doctor, what size of aneurysm do you consider for treatment? And I know that's a complex question, but can you guys maybe try to put some of that in perspective for the audience, some of whom may not be physicians?
Yeah, that's a really tough one. My general feeling is that rules are for fools, but they do help us to some respect in terms of guidance. For someone who's elderly, who has tremendous comorbidities with a limited life expectancy, I would regularly tell them, even if their aneurysm's on the larger side, that potentially there's nothing to do. We can just keep an eye on it. If it's really growing, then we treat it. In contrast to that, to someone who has a 3 millimeter double lobulated basilar tip aneurysm in a 20-year-old with 5 family members, all with a history of aneurysm, with 2 deaths in the family, and her aneurysm grows from like 3 to 3.5 millimeter, grows a new lobule. I mean, that's really, those cases are really worrisome. And so, unfortunately, we do get stuck treating some smallest aneurysms. I think the smallest one I've treated is a ruptured, like 0.5 millimeter aneurysm. And of course, that aneurysm didn't read the rule books or any of the trials or studies.
And Waleed, how do you talk to your patients about size considerations?
Yeah, basically, I echo everything that Bobby said. It is so dependent, on the location and the patient and everything. Like for like a basilar or a ACOM, like 4 millimeters or so, I think is 4 or 5 millimeters is pretty reasonable to consistently offer treatment, because we know that those are more dangerous locations. For MCAs, we watch a lot of these 4 to 5 millimeters, like the ones along the carotid siphon, they're generally pretty benign, but most of the patients, we know that the risk of treating it with like a flow diverter and dual antiplatelet therapy and all that stuff is really, really low. So I think it's okay to offer treatment if it's like, 5 millimeters or larger. So, the issue, the main thing is that, the risks of treatment are getting lower and lower, because, improvements in devices and anti-aggregation therapy. So in the end, we're going to be treating more aneurysms that are smaller, it's just the way it is, I think.
Yeah. Alex, let's hear your thoughts as the last word here, and then we'll call it.
Absolutely. So on aneurysm size or Rapid software?
You pick. You get the last word, my friend.
I will do it on Rapid aneurysm software. I can't top what Waleed and Bobby said about aneurysm size. So again, just taking a step back, what a time to be treating aneurysms. The technology we have, the devices, I think the AI is revolutionizing medicine. I think we're always early adopters. So we're here and driving the change. I think in the next 10 years, we're going to do amazing things. The subsequent 10 years will be things we can't even imagine now. But I'm just fortunate that I'm here at this time with you guys and working on aneurysm patients, and what a time to be part of this. I'm just very excited.
Oh, well, thank you all.